for this informative lecture, and I will open the floor for discussion and the questions. If any question from the audience, any questions? Because online there is no questions.
Histopathology came back for aggressive histopathology like tall cell. Should I regret the lobectomy or extrathyroidal extension? And would you, having histopathology for tall cell tumor, even if I have a very good surgery, as a reason to give radioactive iodine, or just extrathyroidal extension without lymph node involvement? Thank you.
Yeah, it's a great question. So in case those online couldn't hear, the question was, what if at post-lobectomy, one finds out that the histology of the papillary thyroid cancer is more aggressive, like tall cell or one of the other more aggressive, and or you had extrathyroidal extension, do you go in and do a completion? And I forgot the second part of your question, but I'll answer that and then you can let me know. And the answer to that is it's an excellent question, and we don't for sure have the answer, okay? There's a lot of people who feel, oh, it's an aggressive histology, so let me give radioactive iodine, let me do the completion thyroidectomy, which is usually done within a week of the first surgery or 3 months later, because that in-between time of that week and 3 months, there's often a lot of fibrosis, and it can make it, there's a lot of scarring, and it can make difficult surgery, so oftentimes the surgeon will wait, and the outcomes don't change in general. The exception is some of the cases that you see in the multidisciplinary, but in general. The reason it's an interesting question is because it's easy to say, yes, do the completion, do radioactive iodine. But if you have a patient with tall cell, often they have a BRAF mutation, which often doesn't take up iodine, and so people will ask the question, will iodine even help? Right? And it's a great question. It's just not ready for prime time in terms to tell you yes or no. So even within our group, we have people that if they do immunohistochemistry, like they paint the tumor to look for a BRAF mutation, if they see it, they'll say no iodine, right? That's not in the guidelines, but I'm just saying that it's not for sure do it. Does it harm to do the completion with radioactive iodine? Probably not, but obviously the patient potentially could have complications. What was the second part of your question? I forgot. I'm so sorry.
I was asking about extrathyroidal extension in the presence of a negative lymph node. Is it a reason to give radioactive iodine, or the presence of lymph node would be more strong argument to give a radioactive iodine?
Yeah, so extrathyroidal extension without lymph nodes is possible but rare unless it's a follicular type, right? And so it is a reason, the risk of recurrence, let me show you that really quickly. Oh, minimal, oh no. So minimal extrathyroidal extension was downgraded in the new staging system, and so it's no longer a T3 and therefore not at high risk for recurrence, so it's no longer a reason to give radioactive iodine. Now I understand.
Again, I want to thank all the speakers about the lectures. My question about epigenetic factors. I know we cannot modify genetic causes for cancer thyroid, but what about the epigenetic factors, especially this patient? Some of them have obesity, have diabetes, hypertension, and there is a new era of medications like GLP-1 receptor agonist, injections for obesity. Do you recommend some precautions to prevent or to decrease the incidence of cancer thyroid for this kind of patients? And the long-term follow-up. Most of these patients come to us as a family physician, the primary health care. What's your home message for me as a family physician to prevent these cases to be missed or coming in a late stage? How I can take care or follow up these patients? What's your recommendations?
I missed part of your question, but is the question, what are modifiable risk factors to prevent not disease recurrence, but the development of thyroid cancer?
To prevent and to follow up cases who are already diagnosed. What's your recommendation?
Okay, so first of all, we'll talk about risk factors for thyroid cancer. And the only main risk factor that we really truly know is radiation. right? 10% of cases will be radiation. However, and then there are these studies that show smoking decreases the risk of recurrence. We don't tell our patients to go smoke. In fact, I don't even share that data with my patients, right? I don't want anybody smoking. But, in fact, I tell them to quit 1 week before surgery because their outcomes will be better. In general, because patients always want to know what, they're not in control of having cancer, but what can they do? And so I tell patients, I extrapolate from the data in other cancers that shows lifestyle modifications matter, right? So in breast and colon cancer, they've very nicely shown that getting up from your chair 10 minutes more a day than you normally do lowers the risk of death and recurrence from your cancer. So I tell them I extrapolate that from other cancers and I apply it to thyroid cancer, even though I don't have data in thyroid cancer, right? So movement matters, right? 30 minutes, 5 days a week, 150 minutes a week, 1. 2 is if they're obese, losing 7% of their weight mattered in colon and breast cancer and ovarian. And so I tell them, listen, if you're 200 pounds, you don't have to be skinny mini model, lose 14 pounds. Sorry, I should say it in kilos. The third thing is, patients always ask about high sugar diets and, do I quit sugars and do low carb and, starve myself to death? And so I don't have any proof, even though people say sugar feeds cancer and there's studies to show positive and studies to show negative, a healthy diet in general, right, will help. Anything that's pro-body, pro-health is anti-cancer. So those are things that patients are in control of. Everything else, there's a lot of epidemiologic evidence, you can't control many of those things, and so that's typically what I'll tell patients. And that's both for recurrence and development.
Do you recommend adding any tumor marker for a routine periodic checkup for this patient? We do usually annual checkup yearly for our patient, not NCD patient. This patient who have history of operated thyroid cancer, do you recommend any tumor marker to add for periodic checkup?
So TSH and thyroglobulin antibody should always be checked. Other than that, correct. Other than that, we don't have any other markers that help tell us about, imaging, but blood, no.
Thank you so much.
If I may take the opportunity, because I think we have some primary care and general physicians here, and we are seeing an epidemic of thyroid cancer related to inappropriate use of ultrasound for patients going for Mounjaro or Ozempic. I think the current state of practice or recommendation is that don't do ultrasound because the patient is simply going to take Ozempic or Saxenda or Mounjaro if there is no thyroid issue or no family history of medullary thyroid cancer or MEN2. What we are seeing here in Saudi Arabia, and I'm sure around the Gulf, and maybe even outside, is people abusing the ultrasound. So we are repeating the Korean model or Korean story by doing ultrasound for patients who are going for Mounjaro or Ozempic or one of those GLP-1, and creating issues for the patient and for the health system by detecting small nodules that are mostly benign, but sometimes they can be microcarcinomas. So I just want to make that point because I hope that we have lots of people around, and I hope the message gets across, and please feel free to comment further on this.
Ali, it's a great question as always. So everybody across the world is wanting this skinny shot, right? Mounjaro, Ozempic, the oral stuff, semaglutide. Everybody wants this. Everybody wants to lose weight, get a jump start. And in mice, it was shown that those mice can get C-cell hyperplasia, right? So the FDA and EMA came out and said that patients who have diagnosed medullary thyroid cancer, right, should not, and MEN2, should not get these drugs. So patients always come and ask, like, oh, I have papillary thyroid cancer, should I not get on it? So there was one study that came out, I think last October or November, I can't remember, that suggested that maybe there might be an increased risk of differentiated thyroid cancer in these drugs. No other study has confirmed that. And so in general, patients who have papillary and follicular thyroid cancer, we're letting them have these drugs, okay? Now, the important question that Professor Ali was asking is, should we be screening for medullary thyroid cancer, right? Well, first of all, there is no real screening for medullary thyroid cancer, but that is a waste of healthcare dollars and time and anxiety for the patient, because 65% of us walking around have thyroid nodules, and therefore we're going to find something in the vast majority of people who are asking for the skinny shot, right? So screening ultrasound does not need to be done. That's never been the way to diagnose MTC. So no, it's not recommended. It is clogging the system, right, and holding up endocrinologists who need, or radiologists who are needed for those patients with thyroid cancer. And what was the second part of your question? I mean, in general, it shouldn't be used, and in general, not increasing risk of recurrence or development of TTC.
I wish people are just concerned about medullary, but they're doing it across the board. I think basically the message that should go to people that ultrasound is not needed if you want to start the patient on one of those GLP-1, unless the patient has abnormality on the physical examination, thyroid nodule, for example, or the patient has personal or family history of medullary thyroid cancer or MAN2. What is happening now, this is automatic, reflex from many physicians asking for ultrasound for any patient, and they are creating an epidemic of thyroid nodules and thyroid microcarcinoma. So I think the message I want to get across, please don't do ultrasound just simply because you want to start the patient on Mounjaro or Ozempic or Saxenda. If there is no risk factors for medullary thyroid cancer, or if you don't find anything on physical examination, don't order ultrasound. I have another question, Naifa, or another comment. I think the problem we are facing with thyroid cancer, differentiated thyroid cancer, is, as you mentioned, the intermediate group of the ATA intermediate group. It is really very tricky because there is low intermediate and there's high intermediate, and I think maybe, hopefully, I don't know if this is going to happen in the next guidelines. Hopefully, they can filter this farther out and give us maybe 2A and 2, or low intermediate and high intermediate, or something like this.
I will give the chance for last questions, Dr. Ali and Professor Naifa and Professor Ali, because they told me the time is near to finish. But I would like to ask about procalcitonin, Professor Ali. Is there any new about procalcitonin in medullary thyroid cancer?
I would say the answer, but I think I need Naifa for that. No, it is calcitonin, not procalcitonin. Naifa?
Yeah. Professor Naifa?
Yeah, so the question is, if one has obvious medullary thyroid cancer, it's a non-calcitonin secretor. Like Professor Ali had said earlier, calcitonin and CEA should both be made. Very often the poorly differentiated medullary thyroid cancers don't make much calcitonin, but they make CEA, and so both of those should be checked. And if you see a rising CEA and a stable calcitonin, that's a bad sign. There are some cancers that don't make either calcitonin or CEA. So to answer your question, there isn't anything new. It's just an emphasis of checking both markers. Thank you.
Yeah.
Thank you for all speakers, and I will have pleasure to end this nice session, and I will give the floor for the next, I think, closing session. Thank you all.
Thank you.